No, because even patients with high distress may choose no further counseling. Therefore, a third step, we always ask whether the patient wants to have psycho-oncological counseling. For some patients, it is vitally important to get along by themselves. They may even feel that external support would weaken their self-efficacy, which, in the meanwhile, has also been supported by empirical data. There are many possible reasons for under-recognition of psychosocial distress or emotional disorders. For instance, just as not all health professionals ask about emotional difficulties, not all patients want to talk about their psychological or emotional problems. Additional patient-related factors include confidence in the clinician and the belief that help is available. Clinician-related factors linked with low detection include the willingness to look for emotional problems, clinical confidence, and skills, as well as low consultation time. Finally, there are illness-related factors like, for instance, low prevalence or mild severity. There have been several attempts to use problem checklists to support simple ratings of distress. One such study indicated that the most common problems in cancer were fatigue, followed by sleeping, finances, and pain. 2 studies of the Moores UCSD Cancer Center have shown that only about a third of those scoring as significantly distressed on the distress thermometer actually want professional help for the emotional problems. This raises the necessity of a further screening refinement by asking which problems actually require professional help. In conclusion, despite considerable innovations, there remains a gap between those identified as distressed and currently untreated, that is, those with unmet need, and those who want help for these concerns. Clinical care for emotional problems has improved and is more commonly available. However, no unified approach to emotional problems exists yet. In any case, improvement in distress identification will not be effective in isolation and must be linked with physician communication skills and subsequent interventions. Thus, pairing evidence-based detection with evidence-based treatment is an essential step to improve clinical care. Fatigue is defined by the National Comprehensive Cancer Network as a distressing, persistent, subjective sense of physical, emotional, and cognitive tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity and interferes with usual functioning. As such, fatigue is a highly prevalent and distressing symptom in cancer, associated with decreased quality of life, significant psychological and functional morbidity, as well as depression, hopelessness, and overall psychological distress. A study in terminally ill cancer patients has additionally shown that fatigue predicts the desire for hastened death. As we have seen a couple slides before, patients with cancer perceive fatigue as the most distressing symptom, even more distressing than pain, nausea, and vomiting. Additionally, cancer-related fatigue is more severe and more distressing than fatigue experienced by healthy individuals and is less likely to be relieved by rest. Despite its substantial impact on patients and their caregivers, it is still frequently underreported, underdiagnosed, and undertreated. According to the NCCN recommendations, fatigue screening should be performed at the initial visit as well as during and after treatment. The use of numerical self-report scales or verbal scales for severity assessment is highly recommended, since fatigue is a symptom that is perceived by the patient in the first place like pain. In case of moderate to severe fatigue, a focused history and physical examination should be performed, the pattern, onset, and duration be evaluated, associated symptoms assessed. Furthermore, the interference with normal functioning should be explored. Precipitation factors and perpetuating factors should be identified. For instance, acute physical and psychological stress on the one hand, or physical inactivity and ongoing psychological and social stress on the other hand. In any case, external information from family members and other caregivers is an important part of assessment, not only among children and elderly patients. Given the multidimensional nature of fatigue, a biopsychosocial treatment approach is recommended, with interdisciplinary teams addressing needs of individual patients while implementing the treatment guidelines are critical to management of cancer-related fatigue. Interventions can be tailored to the stage of illness, for instance active treatment phase, survivorship, or end of life. A 3-stage hierarchy for the management of fatigue was proposed, namely to identify and treat any underlying cause of fatigue, to treat fatigue directly, and to address and manage the consequences of fatigue. A number of general strategies, non-pharmacological and pharmacological interventions have been recommended by the NCCN guidelines for the treatment of cancer-related fatigue, including energy-conserving strategies and using distraction, psychosocial interventions, and increased physical activation, as well as the administration of psychostimulants and antidepressants, among others. An episode of major depression is diagnosed when a person experiences a 2-week history of either depressed mood or anhedonia, along with 4 of the following symptoms which persist nearly every day: increased or decreased appetite, insomnia or hypersomnia, psychomotor agitation or retardation, fatigue, guilt or worthlessness, diminished concentration, recurrent thoughts of death, including suicidal ideation. One difficulty in diagnosing depression in cancer is that many of the somatic symptoms caused by cancer or its treatment overlap with these criteria. Just as the somatic symptoms may inaccurately be ascribed solely to the cancer or its treatment, the psychological symptoms may also be normalized as an expected consequence of dealing with a life-threatening illness. Pervasiveness, quantity, and severity of symptoms, as well as associated impact on functioning, help to differentiate major depression from adjustment disorder. Another difficulty is to judge the diagnostic relevance of recurrent thought of death, which may indeed be a normal consequence of dealing with a life-threatening illness. As just noted, it is often difficult in cancer patients to evaluate the heterogeneous etiology of somatic symptoms. There may also be an uncertainty about the effectiveness of treatment for depression or a lack of access to psychosocial resources. Furthermore, patients themselves may lack awareness of supportive services or be reluctant to seek treatment and rather focus on physical treatment. Especially soon after diagnosis, there is often a heightened need for aggressive cancer treatment, in the course of which psychological or emotional suffering is often largely repressed in order to prevent the patient from being emotionally flooded and to maintain the patient's capacity to act. Some cancer patients may fear the additional side effects of psychotropic medication, while others may have a discomfort with disclosing psychological suffering related to stigma with or contact with psychosocial services. Many patients may have a strong need to maintain a fighting spirit, inhibiting them to disclosing or acknowledging any distress or perceived negativity. Finally, cultural differences also need to be acknowledged because they may impact the reporting of psychological symptoms. Depression has a rather strong impact on cancer, such that depressed cancer patients report a poorer quality of life, are less adherent to medical interventions, and have longer hospital stays. A review of 70 studies concluded that no psychological factor, including depression, convincingly influenced the initiation or progression of cancer, although suggested regression, helplessness, and chronic depression may be contributing factors. Overall, the evidence associating depression with cancer incidence is weaker than that for cancer progression. To date, it is still unclear whether depression contributes to an increased risk of mortality in cancer. However, experts increasingly agree that a complex relationship exists between depression and mortality in cancer patients, involving multiple biological and behavioral mechanisms, including increases in pro-inflammatory cytokines, decreased NK cell numbers, as well as treatment non-adherence, smoking, alcohol use, and suicide. Thus, although it remains unclear whether treating a cancer patient's depression will prolong survival, there is definitely the opportunity to improve treatment adherence and quality of life. Anxiety is another relevant factor contributing to the psychosocial distress frequently experienced by cancer patients. It is an unpleasant psychobiological emotion that forms part of the defensive structure with a highly variable phenotype. As such, it mobilizes resources to reduce exposure to a perceived danger and activates the primal fight, flight, freeze, and faint reaction. The anxiety phenotype comprises manifold elements, including cognitive components like evaluating both the urgency of threat and the currently available coping resources, while focusing on the threat to the exclusion of extraneous detail. The affective component includes emotions such as nervousness, edginess, fear, worry, and terror. On the behavioral side, it manifests with avoidance, fight, flight, immobility, and the inability to speak. Physiologically, there is a large variety of subcomponents ranging from cardiovascular ones like palpitations and hypertension, respiratory ones like tachypnea, chest pain, and shortness of breath, via neuromuscular like restlessness, tremor, and rigidity, gastrointestinal ones like nausea, diarrhea, and abdominal discomfort, to urinary ones like increased pressure and frequency, or dermatological ones like flushing, paleness, and sweating. In line with this reasoning, anxiety is not of itself pathological, but rather a response to perceived threat. If adaptive, anxiety supports survival by motivating an individual to take steps to reduce or avoid the danger. Maladapted anxiety, in turn, is disproportionate, inappropriate, or independent of the actual danger, and as such leads to the expansion of considerable effort and fruitless worry, thereby serving no endpoint, such as better problem solving. Non-specific physical sensations are often cognitively amplified and misinterpreted as being a sign of cancer, causing secondary worry and anxiety. The noxious intensity and chronicity of maladapted anxiety impairs daily functioning, wears out family and friends, and reduces a person's sense of self-efficacy. Last but not least, avoidance lessens the chance of habituation to the perceived threat, interferes with adherence to treatment procedures, and impairs decision-making. As we already learned, anxiety and depression are among the most common emotion-related distress problems. To determine the level of anxiety and depression that is experienced by a patient, the Hospital Anxiety and Depression Scale is commonly used. This 14-item scale was originally developed by Sigmund and Snaith in 1983 with the particular aim to detect anxiety and depression in people with physical health problems. The HATS scale consists of 7 items related to anxiety, like I feel tense and wound up. and 7 items related to depression, like I still enjoy the things I used to enjoy. Each item on the questionnaire is scored from 0 to 3, resulting in scores between 0 and 21 for either anxiety and depression. Cutoff points of 8 out of 21 for cases of anxiety and depression have been identified in large numbers of studies. The following questions have been taken from the Hospital Anxiety and Depression Scale. Please assign the questions to the feelings anxiety and depression by checking the boxes on the right.